Thank you for inviting me to give this talk. The topic is a familiar topic to this audience, and it has been previously presented a similar topic by Brent and Xueyan. So now there's a tall order for me to present the same topic here. So my goal here, this talk, is to give you an overview of the clinical context of AML MRD and to convince you why MRD detection is important. What I will not get into detail is the methodology itself, which has been excellently covered by the previous speakers. So the AML is a very aggressive disease. Without treatment, the patient dies in a matter of weeks or a few months. So the standard care of AML has been, the backbone of the standard care has been there for almost 40 years without a significant change. The standard AML treatment, including the induction, and at the end of the induction, there is an evaluation whether the treatment response. If it responds well, the patient receives consolidation therapy, and that's the end of treatment. And about 80% of patients actually respond to the treatment, and they can get into so-called complete remission. Unfortunately, about 80% of those patients respond to therapy, they're going to relapse. So then they come up with the approach, and actually started here at Fred Hutch about 40 years ago to do the allogeneic bone marrow transplant, which can significantly improve patient outcome in a subset of patients. Mainly is a high risk or intermediate risk. So this is the standard AML treatment. The treatment response is really evaluated by bone marrow morphology in conjunction with peripheral blood count recovery. The assessment is typically performed at the end of induction at the time of aplasia to evaluate the reduction of the tumor load, and also at the time of bone marrow recovery or the peripheral blood count recovery. Usually that is around day 28 post initiation of the induction. The complete disease remission requires less than 5% blast in the bone marrow without abnormal blast, including aural rod, absence of circulating blast, as well as absence of extramedullary disease. This is standard protocol, still is currently stated by the NCCN guideline. Unfortunately, morphological response does not predict treatment outcome. And here is some unpublished data from our institution. Over 200 patient relapse, and you can see most of the relapse occurred early within the first year after a patient achieved CR, and half of the relapse actually happened within the first 5 months. And after the initial wave, you can see it about a year after there is a prolonged shoulder of the relapse. So there's 2 phases or multiple phases. And in addition to the timing, the early relapse actually has a poor response to any additional salvage therapy. And in the early study performed at MD Anderson, the study showed within the first year, the patient relapsed. Only 14% patient responds to the salvage therapy. And this response will improve if patient relapse later. And by the time after 2 years, relapse after 2 years, and the response rate actually approached to the de novo disease, patient with a de novo disease. This non-responder responsive to the salvage therapy directly translate to the survival rate. A later study showed a similar percentage, and just demonstrate over the time there is no significant improvement how the in terms of how to manage those patients. So if looking back on the hindsight, you can see the patient who relapsed early, they are different from the patient relapsed late. The proximity to the CR and also the resistance to additional therapy prove they are very high risk, and they probably related to the original disease. Whereas the later relapse, they are more sensitive to salvage therapy. They are different. However, at the time of CR, there is no parameter can help to distinguish or to predict which patient will relapse early or who going to relapse late or who going to have a durable remission. So that's why it's become very important, clinically important to further characterize those diseases. And we end up with multiple subtypes of AML, and the significance of those subtypes is directly related to the patient outcome. So the subtypes, as well as other clinical parameters like leukocyte count and the disease status, and the genetic abnormality, as well as now is the mutational profile, together provide a matrix to predict patient response after or predict the outcome after patient achieve CR. For example, the subset AML with the inversion 3 and the mutated P53 with a complex karyotype, they almost universally has bad outcome regardless how they respond to the treatment. By contrast, some other subtype AML, like APL with a 15-17 translocation or inversion 16, they have much better prognosis. So this kind of subclassification is important. However, for a vast majority AMLs, there are somewhere in between those subtypes. For example, A21 or translocation A21 and NPM1 mutated AML. They are somewhere right in the middle. And for any given patient, this kind of prediction is less important. It's really toss a coin whether the patient has a good outcome versus a bad outcome. That is the shortcoming of the pre-treatment risk factor. By contrast, there is evaluation of instead of characterize the disease into different subtypes, we can characterize the treatment response. And this can be done by multiple, in addition to morphology, you can characterize the immunophenotype or genetic or genomic lesion, which can provide a much more sensitive evaluation of treatment response. So this is any disease identified by those approach below the morphologic threshold is named minimal residual disease. But now after nearly 30-year study, we know those diseases, they are very important and nothing minimal about. So now they changed the name to measurable disease. And this concept has been established over 30 years, but it's still not adopted in the standard care or fully described in the textbook. So you end up is we still have to rely on or at least from a learning point of view, you still need to remember all those subtypes of AML. And more importantly is that the MRD status is not factored in many clinical research. So that renders all those previous findings or described in the textbook, they are not necessarily, it's only impartial. The conclusion may change once you include MRD status in the picture. So now the question is, how is MRD detection changing the concept of remission, disease remission? So that is the focus of my talk. And this will come from three different subtopics: association between MRD and the relapse. And also I will discuss test sensitivity and prediction of relapse, mention some challenge and opportunity for further research in this topic. So this is I think is the best data is ever published there to demonstrate the importance of MRD. And this is the work by Dr. Chen. And the work convincingly demonstrates the MRD detected by flow cytometry at the time of CR is associated to very high risk of early relapse. So this captured all the relapse that happened within the first year and perhaps even shorter time within the first 6 months. And this is compared to the population showed by the blue line. And those has a relapse, but relapse at a later time. This data convincingly demonstrates the MRD is associated with early relapse. And this is not the only study demonstrating this kind of phenomenon. There's, I just take examples. And here's a study from Holland, which is Dutch, Belgium, and Austria research group. They demonstrate a similar finding. The MRD positive at the end of induction, which is the second cycle of induction, it has a very high risk of relapse, and those relapse happen early or with a very short duration of remission. What I need to emphasize is those patients has continued treatment. They received consolidation therapy. So those relapse happens quick, and high frequency is in the setting of consolidation therapy. What about the transplant? And the work from our institution demonstrate if there is MRD detected by flow, those patients relapse after transplant. So if there's MRD detected by flow, regardless patient receive chemotherapy consolidation or transplant consolidation, those patients has a very high risk relapse, and those relapse happen early. And on the right side, you see this overall survival curve. It demonstrates once those patients relapse, there is no any further treatment available for those patients. So what if a patient during the course of consolidation, the MRD went away? So you detect MRD early after induction, but at the end of consolidation, MRD disappeared or non-detectable. What happens to those patients? The answer is it's not so good. And this study from a children oncology group actually demonstrated these effects, although those effects has been shown in multiple studies, but this study explicitly addressed this issue. So the MRD study is performed at the end of therapy, it's end of consolidation. And you can see if there's a MRD detect at the end of therapy, the patient has a quick and rapid, the high risk for quick relapse compared to the one as negative. And in the middle is a group patient who has MRD detected early, but cleared during the further treatment, and those patients relapsed anyway. And on the right side shows the relapse-free survival shows those patients corresponds to the cumulative incidence of relapse. So what about the transplant? This is a study from our group demonstrate if patient has MRD before transplant. After transplant, MRD cleared. So I will lead to the curve, green and the blue, those in the middle. Those are the patients has a pre-transplant MRD. After transplant, one of the group, I cannot see clear from here, is, I believe it is the green, is the MRD cleared at the post-transplant evaluation. And the blue is MRD persist at the post-transplant evaluation. You can see those two curves are almost overlapping. There's no significant difference. So the conclusion is if there's MRD detected, neither consolidation even if disappeared after a transplant or consolidation, the risk persists. So if MRD is such a risk factor, in this context, does other pre-treatment risk factors still significant? Or in another way, does the MRD can represent the summation of all other risk factors people has been characterizing or used to characterize patient risk? So the finding based on the MRD detected by flow cytometry, and the study has consistently shown other risk factor remains significant or independently significant. This including the white cell leukocyte count at the diagnosis, cytogenetics, and the disease status. So this summarizes the finding of MRD detected by flow cytometry. Those MRD is typically associated with the early relapse. And the risk associated with those MRD cannot be effectively controlled by consolidation with the chemotherapy or stem cell transplant. Although the transplant does provide a better outcome in those patients compared to conventional chemotherapy. And the MRD detected by flow only identify a subset of patients with early relapse, does not capture all the patients, and also other risk factor remains significant. So this third point highlight the MRD detected by flow is incomplete. It does not capture all the patients in risk. So the question is, does a more sensitive MRD testing will improve the prediction? So this is a study, the best study out there on those are the use of RT-qPCR, which can provide analytical sensitivity down to 1 per million cells, or 10 to minus 6, which is 10 to 100-fold more sensitive than the best flow cytometry detection. So most knowledge were accumulated is on AML with 821 translocation or AML associated with a mutated NPM1. So here's a study published in 2013 that demonstrate the level of MRD detected by RT-qPCR is an independent prognostic risk factor for relapse. So compared to the flow, I like to point out two improvements. One is you can see this blue line shows the MRD above 1% based on their ratio, the mutated NPM1 versus a housekeeping control. And remember the MRD detected by flow, those patients relapsed almost all within the first year or even earlier. And here we can see the relapse, the range of the duration of a relapse actually much broader. This including early relapse as well as the subset of patient relapse after the first year. This is, I consider this as a sign of improved sensitivity, made or clinical significance of those improved sensitivity. And the other point is, by doing multivariate study, you can see the risk factor associated with the leukocyte count, or the high risk genomic factor, the FLT3 mutation. And those high risk factors lost significance when adjusted for the MRD detected by RT-qPCR. That's the second sign indicate the sensitivity, analytical sensitivity does translate to predict a clinical outcome. And the other study has used a similar technique, but instead of testing on bone marrow, they test on peripheral blood and showed similar results. And furthermore, the same group also demonstrated the MRD detected by RT-qPCR. If patient only receive a conventional consolidation, those patients relapse. But if the patient receive bone marrow transplant, they can actually, a subset of those patients responds to the transplant, and there is a significant improvement. And this is also different from the observation we made based on the flow cytometry. So in a summary, the MRD associated with relapse has the MRD detected by more sensitive detection method. They are associated with the relapse with a broader duration of remission. And the transplant can eliminate the risk in a subset of patients. And the MRD, in the multivariate analysis, MRD can be the only independent risk factor. And the other risk factor like FLT3 or KIT mutation lost their significance in this context. And but at the very low level, or the RT-qPCR can be too sensitive. So at a low level, the positivity don't have a significant clinical significance. So those are the studies performed separately based on flow and the molecular. So what if you compare flow and the molecular? Does the molecular provide additional benefit if the same specimen or the same risk evaluated by flow cytometry? And in earlier study in Hsinchu, the Children's Hospital, their study actually indicate the molecular testing does not provide significant benefit. So this figure shows if a patient is a flow cytometry negative, and the molecular positivity does not render a significant risk compared to the one without molecular MRD. But does this also apply to adult or to a different setting without a marrow transplant? So that's the starting point. We put a research project together to analytically and clinically compare MRD detected by NPM1 and NGS in adult patient with mutated AML with the mutated NPM1. So this project we consider is a low-hanging fruit in the MRD study. This particular subtype of AML now is a provisional subtype, or it is true subtype in the update WHO. It's the largest subtype of AML. It has a very stable this disease-driven mutation, NPM1 mutation. This mutation occurs in more than 95% disease relapse. Means this is a true leukemic driver. And this subtype of AML has characteristic phenotypical abnormality. And more importantly, we have this test in-house with a high sensitivity NGS testing. And this method is established by Steve and David. And the proof of concept study was published in 2014. And it shows the linear lower limit of the quantitative detection can get down to 0.01% of the neoplastic cells. And over the year and a half, we accumulated a lot of data, and this figure just shows the blank control versus the SPECT positive control. It shows a very stable performance, and the background is less than 0.002% in terms of variant frequency. The positive control, we can detect 100% if a SPECT in 0.05%. And at 0.01%, we can detect most of it, the SPECT positive control. So analytically, we compared the MRD detected by NGS versus flow cytometry. In this table, the flow cytometry report is a binary, positive versus negative, and the NGS result is presented as an ordinal bricked at 0.5 and 0.05 and 0.005. And remember, the NPM1 mutation is a heterozygous mutation, so 0.5% is equivalent about 1% neoplastic cells. And here we show at 0.5% cutoff, about 94% of the specimen also flow positive. And this concurrence dropped to 46% when the mutation present at 0.05 to 0.5% in that range, which translates to 0.1 to 1%. And below this 0.05, almost all the specimen with the mutated NPM1, its flow is negative. And we also quantitatively compared those two type MRDs, flow versus NGS. It shows if both are positive, there is a relatively good correlation. And with R is 0.7, R squared going to be only about a half. There is a subset of specimens has a higher proportion of mutation compared to the flow. This is really not come as a surprise. In the earlier study by PCR has been people demonstrate compared to the blast identified by morphology, at the lower range of those positive specimen, often the PCR identified higher fraction of mutation compared to the blast percentage. So given those analytical comparison, we also compare the clinical significance. This is done in two aspects. One is we compared significance of MRD detected by NGS at CR to the flow cytometry after in a subset of patients who received the induction consolidation without a transplant. And this is a cohort including 35 patients. They received the induction consolidation. And the MRD study performed at the time of CR or within 3 months after CR. Out of this 35 patients, 20 relapsed, 2 died without relapse, and 13 remained in remission, and with a 22-month median follow-up. So here is the difference between difference in the outcome between patient with MRD detected by flow, which is highlighted by the red line, and the flow MRD negative, but NGS MRD positive above a threshold, 0.02%, versus a group of patient without or with a very low NGS MRD. And you can see there is a clinical significance between all three groups, despite a very limited number of patients in this study. The flow positive group showed a consistent relapse pattern comparable to our previous study. But the NGS really identified a subtype of patient. Most of them relapsed late at the time. In this particular study, the median relapse time is 14 months compared to 3 months, which are flow positive. And we also compared the significance of MRD detected by NGS and the flow cytometry at the time in patients who received transplant. And this is done in 59 patients who received the bone marrow transplant for either de novo or relapsed AML with NPM1 mutation. And the MRD evaluation performed 2 to 6 weeks before transplant and 3 to 5 weeks after transplant. So in this cohort, 20 patients relapsed, 9 died without relapse, and 30 remained in remission with a 23 months median follow-up, 3 months. So we started including all the conventional risk factors to compare those, including age, gender, which abnormal cytogenetics, FLT3 mutation status, disease status is a de novo disease versus relapse disease, and at the time the CBC recovery, myeloablative versus non-myeloablative, acute GVHD, and the donor type, which is a common parameter people compare for this type of study. And we showed individually the disease status is significant. If patient has been relapsed before and they has a worse prognosis compared to the other patient, and the acute GVHD has a borderline, not quite significant, but it's perhaps because of limited number of patients. But the important thing is the MRD detected by NGS has a different clinical significance before and after transplant. So remember, we previously demonstrate if MRD detected by flow before transplant, those patients relapse, regardless whether they are positive or negative at the time after transplant or at the time of bone marrow engraftment. But here we show that there is a subset of patient, and those are highlighted actually in this red line here. That is, the top 2 panels shows the pre-transplant MRD status, and the lower panel showed the post-transplant MRD status. And on the right side is cumulative incidence of relapse versus relapse-free survival on the right side. The red dashed line showed the patient with MRD detected by flow before transplant, and the green showed the MRD detected by NGS but not by flow before transplant versus MRD negative patient, which is showed in black. And here we demonstrate the flow is positive, but MRD detected by NGS has no clinical significance. But this is quite different compared to MRD if it detected after transplant. You can see that both MRD detected by either flow or NGS has a significant risk, very rapid relapse compared to the patient without those 2 type MRDs. And those, the MRD detected by NGS is in a similar level if they are negative for flow cytometry MRD. So this shows even the same level of or a similar level MRD detected by NGS, their significance is quite different. Or the transplant can really neutralize the risk associated MRD detected by NGS, but not by flow. Adding together, combine the pre-transplant MRD detected by flow and the post-transplant MRD, the test provides a high sensitivity to predict post-transplant relapse. In this study, we showed that there's 83% sensitivity, identified 15 out of 18 patients relapsed with a complete study. And in the multivariate analysis, the post-transplant MRD, either flow or NGS, is the significant risk factor. In this context, the pre-transplant MRD actually lost its significance, but the disease status, the prior history of relapse, and the FLT3 are kind of borderline significance as an independent risk factor in the context of a post-transplant MRD status. So the flow MRD simply is the iceberg flow above the water, right? It just represents higher level molecular, the MRD can be detected by molecular approach. Here we just demonstrate that point. Compare the NGS or the VAF level in the flow positive group versus flow negative group. We can see there is statistically there's a higher mutation detected if flow is positive, but those two groups has overlapping. If we just look at the MRD detected by NGS, regardless of flow cytometry data, we can identify this high-risk group if we apply a cutoff at 0.02%. So the conclusion of those studies shows that flow cytometry MRD testing can be highly specific. That's by compare our flow and NGS. And the MRD testing identifies most patients in high risk for early relapse. And the NGS testing for mutated NPM1 improve MRD detection sensitivity and identified additional patients who are in risk for relapse. And this is especially important in post-transplant MRD assessment. And those data actually emphasize MRD threshold varies depending on clinical context. So with all those data, how do we think should we redefine disease remission, given we know subset most disease relapse early, post-treatment response, and those early relapse, they are more likely resistant to further therapy. So if we put MRD status in the picture, at the time of a CR, we can see that there is a MRD can be detected by flow cytometry, and those patients, regardless they receive a chemotherapy or transplant for consolidation, they are likely to have a much higher chance to have an early relapse, and they are not responding to salvage therapy. And compared to those, there is a group patient who has MRD can be detected by high sensitivity molecular testing, either PCR or NGS. And those patients likely to have, if they are MRD or flow MRD negative, those patients likely to have a risk. They also have an increased risk for relapse, but happen at a later time. And those patients is treatable by chemotherapy, and they respond well to transplant. So given all those differences, we can see the MRD status is very important in terms of how we redefine disease remission. And this is an ongoing process. At this point, MRD is still not adopted in ACCN guideline, at least in last year. However, the European Leukemia Net has included MRD or as a MRD negative as a part of CR status. That is a separate category. So this concept is still changing, and is not this redefinition has not complete. So, what are the challenge and the opportunity in the MRD study? One is improve MRD detection. We know there is still a significant subset of patients they relapse without prior MRD. And this is in the three aspects. The improvement can be made: analytical sensitivity and specificity, broader applicability in terms of different subset of AML, and the test standardization. So flow has a moderate sensitivity, if we can say, and has a broad applicability to almost 90% AML cases, but the standardization is a challenge. By contrast, PCR is sensitive, specific, is relatively easy to be standardized, but it's limited to only a few subtypes of AMLs. And in this context, the future perhaps in the NGS, especially with error-corrected NGS, this has been the concept is established in 2015, and our lab department, Steve and David, and just recently has the paper published on hematologic, prove a concept, uses SNPs to improve sensitivity, detection sensitivity of AML MRD, and the other lab also doing similar kind of work. And this is still ongoing, and how the NGS will improve those detection is people still exploring the possibility. A recent paper published in Journal Clinical Investigation actually, I think, set up a gold standard in terms of how to use a multiplexing test for MRD. And instead of use NGS, they combine the NGS, but they translate that data knowledge to a panel of digital droplet PCR. And this has their testing sensitivity is down to 0.001% or even lower, depending on the particular probe set. They can prove the concept in 72 patients. And this is a really, I think, going to be a very costly study. They use the rain dance to generate 3 to 4.5 million droplets to study the MRD, which means they can interrogating over several million molecules in terms of the defined sensitivity. And this their finding actually support the concept. The MRD study can identify most of the patient who has risk for either early relapse or even late relapse. You can see the separation of those two groups. They applied either they can set multiple cutoff to examine the risk of relapse, versus they can use a single cutoff, set up a binary category, positive or negative. And you can see the positive group, they all relapsed within a certain time point. But if you compare the overall survival on the right side to the relapse-free survival, I think the conclusion is still true. The late relapse, they have a subset of those patients is treatable. They have longer overall survival. You can see the shoulder over here. And then there is a rapid relapse early. So this is a demonstrated approach. If you use a panel high-sensitive molecular study, you can apply to various subtypes of AML to improve the applicability of detection in this heterogeneous disease. But I also like to point out this the top here. This is indicate the patient in a rare patients in the group they are MRD negative. Even use this highly sensitive test, they can still relapse or have an early relapse without detectable MRD. This leads to the second challenge. Does the sampling bias contribute to false negative? So we consider AML as a disease homogeneously distributed in the bone marrow. And that's probably true, but we don't necessarily know well at the level 0.01%, right? So the comparison bilateral sampling or testing on the peripheral blood, or even correlate with the radio imaging study, those are all people have been trying, although there is not enough data to really demonstrate the clinical utility. But you can hear people talk about this kind of topic in the meeting, and there's a small cohort studies. There's a study published by a Dutch group, and they have done very nice paper. They demonstrate the homogeneous distribution of the neoplastic cells in bilateral sampling as well as compared to the peripheral blood. And this type of study has not been performed in AML. So whether it's worth to do similar kind of study, that's still debatable. The third question is, how does MRD lead to disease relapse? So we know not all the MRD is the same and not all the relapse is the same. So how does MRD become a relapse? There's different theories, and perhaps it's a combination of all those possibilities. And the first one is this so-called Big Bang model of oncogenesis. There is a cumulative, without a selection pressure, a mutation accumulate, and some of those mutations are render a chemoresistance. So the induction, post-induction MRD or relapse, it just come out from those subclones. And the other theory is leukemia stem cells. This is cancer stem cell versus cancer. Those stem cells, they have the property of a stem cell. They are kind of, they don't proliferate fast, but they have a capacity self-renew. They are dormant, and they're resistant to the environmental changes. Those kind of property of the stem cell, and they're leukemic stem cells. So by that definition, they're going to resist to the chemotherapy, and later on they're going to grow back as a tumor. And the third is a pre-leukemia clone with a high malignant potential. It's really become the second primary disease, or the therapy-related AML in the years later. And this has been shown, this so-called CHIP, clonal hematopoiesis without indeterminate significance. Those clones actually can be selected by chemotherapy treating other malignancies. And those is an ongoing study. And I think that for us as a laboratory, how to characterize MRD can be compared to kind of characterize the proliferative potential versus their stemness. So there is a recent paper published on Nature as well as on Blood. they demonstrate those stemness actually can be identified, and you can really characterize them. And they, people publish this 17-gene stemness transcription pattern. You can use those, identify subset patient, subset cells. So in combination of a single cell genomics, actually people start publishing this type of paper, combine the characterized stem cells, self-renew property versus proliferative property. So I think those has an implication in terms of how the patient should be treated. So the take-home message is MRD testing is changing the concept of disease remission. It's a still ongoing process. Not all MRD and relapse are equal. And so this comes to the point, MRD testing require an integrated approach in terms of samples and sampling time, as well as detection method. And in the future, the MRD status perhaps will become essential for personalized AML treatment. So last but not least, I like to point out is MRD testing is a high complexity and resource intensive task. And if MRD testing become a part of a standard care, how to manage this kind of test on the business side perhaps is a challenge. If there is no corresponding testing code for MRD testing at this point. So at the end, I like to thank Dr. Wood. His decades work on MRD actually set up a platform for us to have an interest in this subject. And also the data accumulated in this lab over the years actually is a very good resource for this kind of MRD study. And also I like to thank David and Steve and the genetic group set up the NGS platform for us to really try the idea, and we can do it as before other lab can take on this. And also I like to thank Eli and Roland on the clinical side. They really provide a lot of the cooperation and input to improve the work we did. And finally, I thank Megan. She performed all the statistical analysis and also flesh out the ideas how we approaching those data. Thanks.
Thank you very much. I was going to ask something about this correlation between the flow and the detection with PCR and next-gen. So is this related to the viability of the cells? Like, is it related to those cells like dying with apoptosis or, releasing the DNA, but they do not keep their viability enough for us to detect them with the flow? Has anybody looked into that? I was wondering whether there's anything that explains the...
That's a good point, actually. I don't think anybody really published on that, or at least in the context of MRD. Perhaps in the other type of studies, I'm sure there must be some kind of data out there. In terms of the viability, yes, so if dying cells, but that depends if you're looking at that's come to the point of the timing of the test, right? So if you test too early and the cells still circling around or still there, and you may get a molecular signal, but the flow may not. So that's why we don't like to test. I mean, I think there's a data on that. The molecular data compared to flow, the molecular gonna clear out 30 days after starting induction, and the flow perhaps 3 weeks, somewhere in that ballpark. So yes, you don't want to use those sensitive tests, test too early, otherwise give you a false positive.
So that's a very nice talk, thank you. We've been over 30 years ago, people figured out how to detect minimal residual disease in follicular lymphoma with BCL2 IGH, and people have been doing RT-PCR for BCR-ABL since the early 1990s.
Yeah.
And so our technology has, the technology's moved forward in great ways. But I guess the question is, has anyone actually been able to show over the years whether detecting minimal residual disease has actually improved outcomes at all? Is anybody doing clinical trials to actually show that taking some sort of action based on the detection of these very small numbers of neoplastic cells is actually changing disease outcomes?
That's an excellent point. So what we know now, it probably people already know it 20 years ago. So, but there is no big hurry to really designate MRD as a subtype of response, because there's really no effective way to treat those diseases. And still now, the standard care is, or not standard care, not necessarily, is there is MRD depend on the patient, and you end up still wait till the patient has a full relapse and treat. The fact is we only have a limited option to treat those diseases. It's an induction, 7+3 or some variant on that. The whole half of WHO book is really define who should be treated by the induction and who should receive transplant. All those classifications is regard to that. But if you give an induction and patient has MRD, you don't have a second way to treat. I think that's really the cause of the delay to recognize the significance. But now things are gradually changing. There is a different therapeutic approach, the immunotherapy, the inhibitor of BCL2, the checkpoint inhibitor, or even this so-called mini transplant. All those things can become available. The key really is now the clinical trial design is not specific for MRD. They incorporated with the induction therapy. So they are not looking at a subset of patients who are MRD positive, how you treat those MRD to change the outcome. I think that's perhaps going to be done in the future. But before that happens, we need to improve the MRD detection. Right now, most data showed is a probability. So you have MRD, there's a probability 70% relapse, 30% not. But how that translates to a personalized management is still a challenge. For any given patient, it's no longer a probability. We need a certain certainty on that. So I think that's why we need to consider improve the test itself, improve the sampling itself, how to add all those available data together, become a matrix, big data, and to end up with a personalized decision. So I think we're at that point to consider those. But in the last 30 years, we're just not there. All right, thank you very much.